Dr. Kjaesgaard Andersen, who will now report from workshop session number 2 on healthy aging. He represents EFORT and will introduce himself further.
Thank you very much. Thank you for having the opportunity to be here and to assist in giving this report. I'm a Secretary General for EFORT. EFORT is the European Federation for Orthopedic Surgery. We are totally 43 nations and totally 34,000 orthopedic surgeons. And orthopedic surgeons, most of our patients come to us due to pain, so therefore it's extremely important for us also to participate in this debate here. I have the big task to summarize 12 speakers yesterday in our workshop. And I decided to go through all the 12 presentations and dip down in some of these topics which were important yesterday. And I have no disclosures regarding pain treatment in my daily practice. Our first speaker was Jos Kleinen from UK. He is coming from a Kleinen Systematic Review Center. And as you can see out of the presentation here, he stated that in 2050, 30% of U27 population will be over 65 years of age. And he also, like more of the speakers yesterday, presented that the healthy year by 2 should be something we all are aiming for. His basic presentation was a systematic review where he looked at the role of chronic pain in improving quality of life. And on top of this, he found 6 scientific papers and another systematic review. And his result was that the clear correlation between quality of life and severity of pain is stated in the elderly. And the statement from him was that the structured program is needed for treatment of pain in the elderly. Our next speaker was Michel Reneman from Holland, from Revaliditati. He has a focus on a non-specific musculoskeletal pain in his daily practice, and he stated for us that it was a very impact on pain on work. He has made a review on work is generally good for health of the well-being, and he's discussed with us how we should measure that our treatment is very effective. And he very, very presented the absenteeism which is needed to be defined to show in the future in research. So he and his group is now defending a thesis in Holland, and he presented the studies which is based on this. And there were very interesting things in these studies. So he has new data on staying at work and with pain, 7 studies totally. In his review, he stated that the duration of pain was not significant with stay at work. That was something very interesting. And then he made a study on why stay at work with chronic pain. And this was very, very clear that it was to keep life value, it was the therapy, and it was also to keep the income. So if you probably would love to learn more about it, you should approach Michael Reneman and have a copy of the thesis coming out of his clinic later. Our next speaker was Stephen Beeman from UK. He represents the Work Foundation, which is founded in 1918. He could tell us that work is very good for people's health. He could also tell us that musculoskeletal pain at work is something which is very recognized across the European countries, and that back pain is very, very significant. 50% of all people is recognized to have back pain during their life, and 33% of people suffer from back pain during their work. So in Sweden, they have even calculated that 7% of the cost of healthcare could be compared to what is sick leave for back pain. So he stated to us that early intervention is to prevent chronic back pain is something which has to be focused on in general. Not surprisingly, but very nice to hear, is that good management at work is very mandatory to have less sickness absence due to chronic pain. So he also at the end could tell us that with aging population, aging workload, this will increase the risk of having chronic pain. A very, very interesting topic was presented by Wilco Achtenberg from Holland, pain and impaired cognition. And in fact, they had their 4th international meeting running just this spring in Holland on that topic. Pain experience is something which it was discussed to be very complicated in dementia, and we need to focus on this in the future. And he could tell us that pain also changes in behavior in the elderly patients. But assessment, as we heard earlier this morning, on pain in dementia is a very, very big problem. We were shown pictures on how we should try to look in the patient's face to see there what sort of pain or what type of pain the patient was having. But it's clear that non-verbal measurement tools is needed to evaluate pain in dementia. And also, all sort of evaluations should be recognized because it's very difficult to rely on. My very good friend Tony Wolf from UK, which is the chair of Bone and Joint Decade 2010 and 20, and also the project coordinator of European Musculoskeletal Survey and Information Network, presented something about musculoskeletal pain. And this, in fact, is the most frequent long-term pain and physical impairments which take place. Musculoskeletal pain is a lot of different things, but mainly it's joint arthritis, it's rheumatoid arthritis, and it's spinal disorders. But not to forget also results out of traffic accidents. We have in our orthopedic practice a lot of patients with chronic pain resulting from traffic accidents. Interestingly, he could tell us out of some studies that, for example, in Holland, 75% had pain for more than 3 months in the last 12 months. This is something very, very dedicated. The main cause of pain in the musculoskeletal region in the young patients are from sprain, and clearly in the elderly for degeneration. But in the future, we probably will see much more pain from osteoporosis and their related fragility fractures. We had then a presentation by Sylvia Burn from France on pain in the geriatric care. She's coming from Marseille and also organized in France Geriatric Association. And she could state with us that pain is undertreated in the elderly generation. They have earlier reported on Doloplos, which is a 3-dimensional scale, but they went away from this and created Algoplos scale, which is 5 items, and these are the items below. You can see facial expression, look, complaints, body position, and atypical behavior. They asked for having more focus on evaluating and pain treatment and education for the persons who organize in nursing homes. Chapman from UK could discuss with us the quality of pain treatment at the end of life. He is coming from the National Council of Palliative Care, where he's director of the policy. And he stated that pain is a human right. Pain relief is a human right. But it's not all about pain. But the setting of the pain should be in the right scope. One of the big things here was the cancer patients is very scared of dying of pain. And this had a deep discussion in it. But the problem here is that we were told that not always we can do much about it, but we can do something about it. But the statement which is in bold here is very significant, because if we as treaters, it's not expected to be bad. If we expect it to be bad, we are not so surprised if it falls. So it must, in the future, be very much dedicated. Then we have a very short and quick visit from a European commissioner, being late flight in and should be quick away again. But we had a presentation on the European Commission from DG Sanko. Mainly, she discussed with us how to approve the EU Commission to having funding. She went through in details what could be done from basic research groups. And then she left us with the possibility of making an application for being funded. The deadline is today. So if you have some few minutes left, you can send an application. But at the very bottom, you can also find the web page you can go to. But finally, she recognized that there are on the website marketplaces where we can go and look for how to get funded. Chris Rell from UK dealt with us the National Health and Wellness Survey 2010 for the over 65 years analysis. This is our coming president in EFIC, and he also, like other speakers, told us about 2 years of extra healthy life. They have made a study on 60,000 patients across the 5 big nations in Europe, more than 65 years of age. And they found, like we heard more times yesterday, that 20% is in chronic pain. A little discussion was then why the difference was between UK and Italy with 30% and 11%. And the only difference we could find was sunshine and wet wine. But basically, this comes up with 52 million chronic pain patients in these 5 countries, and that's a lot. So the elderly patient is in pain in a very high amount. And we were told that elderly patients visit much more the doctors and the clinics than the younger patients, so they are a bigger burden for our society. And the next presentation was also, like all the others, very interesting. Marie-Therese Garcia-Baco-Merino from Spain is the organizer of a palliative care group in Madrid. Madrid was told to us to be local central with 3.2 million, but with the suburb totally 6.5 million. They have made a very interesting survey because they have this service that you can call in if you have any problem. And in 1 year they have 17,000 calls. 15,000 of those were due to pain. So in the palliative care unit, chronic pain is a very, very demanding thing. So pain treatment in palliation was told to us to needed to be an institutional change in the culture. And they have had different programs running since 1990, so they were very experienced in it. And like others yesterday, they discussed that holistic care is needed, and they have a very good mission to diminish unnecessary suffering for the future. Our next final speaker was Teresa Petrononi from Italy, from Pain Alliance Europe. She stated very clearly that the mission is to improve the quality of life in patients with chronic pain. And they were having a commitment to the protection of the individual's right and a very, very clear motto, we are not born to suffer. And finally, we were having a presentation by Giovanni Gambassi from Italy, Pain in the Geriatric Field. He came with some very interesting statements. And there was much behind these statements here, clearly. I will just read them slowly for you because looking into them, I think most of us get some good feeling of what it is. Older adults feel as much pain as anyone else. Pain generally speaks only one language. Chronic pain is persistent in most cases. Pain is there even if not suspected. Pain does not come alone. The best example is it's related to depression. Pain is not a joke. Pain as part of a geriatric evaluation. Pain is a pain. Pain research has a gap. Future pain for older patients, nothing really happened in the last 10 years. That was his statement. Whether it's true or not, I don't know. Thank you very much.